Good afternoon, ladies and gentlemen. My name is Patrick Wouters, and I have the pleasure to introduce Professor Stefan de Hert, Professor of Anesthesia and Research Coordinator at the University of Ghent. And he's also the chair of the Scientific Committee of the European Society of Anesthesia. And Stefan was leading the Guideline group, or the group that developed the guidelines on preoperative assessment in our society. Those were published in 2010, if I'm not mistaken. Today, Stefan is going to focus on preoperative cardiovascular assessment for non-cardiac surgery and what is new in this field. Stefan.
Thank you, Patrick. Good afternoon, or hello, everybody. I'm really surprised that despite the early or the late start of the Congress, you're all here already. So I have the chance to discuss the preoperative cardiovascular evaluation of the non-cardiac surgical patient. You know that there have been a number of guidelines published in the last 5 years, and in the meantime, a number of things have happened, a number of new concepts have arrived that make it necessary that at least we try to put some things in perspective. And that's why we decided to give you an update or to discuss with you a number of issues around, surrounding the problem of cardiovascular assessment of the non-cardiac surgical patient. First of all, I have no conflicts of interest to declare with regard to this talk. So let's start with the problem. If you talk about guidelines, if you talk about a preoperative assessment, a preoperative cardiovascular assessment of a patient, the first thing we have to know is whether there is a problem. Is it necessary to give a preoperative assessment of a patient? Well, I found you some numbers which are actually a little bit scary. There has been a very nice review article by Philip Devereux, you know, the guy from the POISE study, who took all lists of publication together and tried to look at the incidence of possible cardiovascular events. And when you look at here, you take a group of patients that are at risk for cardiac disease, patients with coronary artery disease, patients with hypertension, with diabetes, all these patients that are at risk. And they come on your operating table. Well, when you look at the incidence of cardiac death, about 1 patient in 100 will have a cardiac problem, will die from a cardiac problem. And when we look at major cardiac outcomes, 4 in 100 patients will develop some problems. Now you can say, okay, that's what I expect. Patient is at risk for cardiac disease, so he will develop cardiac problems. But let's look a little bit further. If you take your group of unselected patients, so the random patient that comes on our operating table and that we anesthetize every day, you see that a major cardiac event occurs in 1 to 100 patients. This means, dear colleagues, that each 1 in 100 patients you treat, you anesthetize, will develop in the perioperative period a cardiac problem. So it's perhaps very interesting to at least try to identify those patients and, if possible, treat them as much as possible so that these cardiac events can be prevented. Let's move to physiology. What is the big problem or the big cardiovascular problem when you are dealing with patients in the perioperative period? Well, the problem is the occurrence of a perioperative myocardial infarction. And if you take into account that mortality rates may rise up to 15–20% with perioperative myocardial infarction, it's very important that we try to prevent it as much as possible. What you need to know is that the concept or the entity of perioperative myocardial infarction has, in fact, when we talk about perioperative myocardial infarction, has in fact 2 main causes. The cause, we all know the best, is the occurrence of myocardial ischemia. Whenever oxygen demand increases above oxygen supply at the level of the heart, you get myocardial ischemia, and if this myocardial ischemia takes sufficiently long, you will have a perioperative myocardial infarction. And when you look at the setting of anesthesia and surgery, your patient is hypothermic, your patient can be hypoxic, so there is indeed a reason to develop perioperative myocardial ischemia and perioperative myocardial infarction. However, very importantly, there is also an entity of acute coronary thrombosis. How can acute coronary thrombosis occur in the perioperative setting? Well, first of all, you have a period of stress. This period of stress will induce shear stress at the level of the coronary arteries. And if you have a thrombus there, this thrombus may rupture and lead to acute coronary occlusion. This is certainly true in a situation of hypercoagulability and in a situation of inflammation. And it's specifically these situations that we witness in the perioperative setting. So yes, there is a risk for perioperative myocardial infarction, either related to the occurrence of prolonged myocardial ischemia, but also possibly related to the occurrence of an acute coronary thrombosis. So I hope that you will agree with me that guidelines and preoperative assessment of a patient may be necessary. So we have developed guidelines. Guidelines are very good, but the main problem is that these guidelines should be adapted. And there has been a very interesting article a few years ago coming from the Netherlands, and I will immediately explain why this is so important. And what these people observed was a group of Rotterdam. They observed that the guidelines appeared to be very poorly implemented. Actually, this was a study that used the ACC-AHA guidelines, the 2002 guidelines, which were at that moment available. And they looked in different hospitals in the Netherlands, in vascular surgery patients, how these guidelines were implemented in the preoperative assessment of patients. A period of about 6 months, which is very feasible. And why is this very important that this study has been conducted in the Netherlands? Because in the Netherlands, if there are guidelines, normally people adhere to these guidelines. I've worked for several years in the Netherlands, and I can assure you that one of the countries where guidelines are the best followed is in the Netherlands. If you would do that something like that in my country, Belgium, probably there are guidelines, but nobody will follow them. So, okay, what were the results? What I would like to draw your attention on is this group. So you have a population where there is no invasive testing necessary, but look at the population where there is non-invasive testing, additional testing necessary to at least look at the cardiovascular status of the patient. Well, you can see that about 80% of the patients that should have had a preoperative assessment didn't receive that preoperative assessment. And what is even worse, if you look at the medication, as you can see here, either statins or beta blockers, the treatment that those patients at risk get is completely similar to the treatment that the patients not considered at risk get. So, the conclusion of this study was that there is a poor agreement between existing guidelines and the actual implementation of these guidelines, even in countries where guidelines are normally followed. Even worse, all those patients at risk got no additional treatment, which means that they were not prepared and that they were at increased risk of developing perioperative problems. Okay, we see a situation there where guidelines are present but are not followed. Is there any reason why this is? Well, when you look at these guidelines, these American Heart Guidelines from 2002, and here you see the flowchart, you can easily imagine why these guidelines are not followed. If you have to follow all these different steps, 9 consecutive steps, with all arrows interacting, it's easy to understand that such guidelines will never be followed. And that's one of the reasons why in the upcoming years or in the later years, new guidelines have been performed. And the first guidelines that were re-established, re-updated, were the American Cardiology Society guidelines, who were published in 2007. Later on, about 2 years later, the European Heart Association, endorsed by the European Society of Anesthesiology, also made the guidelines for the cardiovascular assessment of the cardiac patient at risk in non-cardiac surgery. Were published in the European Heart Journal and simultaneously published in the European Journal of Anesthesiology. So you can find them. And very recently, Professor Wouters already referred to this setting. Very recently, we have published from Europe the preoperative guidelines, evaluation guidelines. Okay. Let's look a little bit more in detail to these guidelines from the American Heart Association. Let's start with this one. So the first question you ask is my operation urgent or not? Is the operation urgent? Yeah, then you need to move to surgery, even if you know that your patient is at risk. Is there no urgency? Then you can start looking at a further assessment, cardiovascular assessment of your patient. And the first question you ask is there any active cardiac condition that needs treatment or that needs at least further evaluation? If this is the case, then you have to evaluate the patient and treat them according to the guidelines, which means for us, in fact, you refer this patient to a cardiologist and ask him for optimization. Are there no active cardiac conditions? And I will immediately discuss with you which cardiac conditions are included. Then you look at the risk of surgery. Is this low-risk surgery? Well, okay, then there's no problem. You can move to further surgery. Is it a high risk or an intermediate risk surgery? Yeah, then you know that probably if your patient is not completely assessed and completely prepared, that you may have some problems. So what is the best way to identify a patient that will develop during a high-risk surgery, that will develop potential problems? Well, it's very similar. Very simple. You just ask that patient what he can do, what his physical capacities are. Okay, I talked about active cardiac conditions, which should trigger you to either further assessment or not. Which are these active cardiac conditions? Well, first of all, unstable coronary syndromes. If your patient has unstable angina, don't start to anesthetize them because you will get big problems, and refer them for further evaluation and treatment. Another active cardiac condition that should trigger you not to start with anesthesia is the presence of decompensated heart failure. It's all very obvious, in fact. Severe valvular disease is also a problem. And when we talk about severe valvular disease, we mainly refer to stenosis. Both aortic stenosis and mitral stenosis can be very dangerous settings. Insufficiency, regurgitation, is less important or is less dangerous in the perioperative setting. If a patient is asleep, he easily can sustain important regurgitation, both aortic and mitral valve regurgitation. But stenosis is really a problem. And then finally, the other cardiac condition that may be important is the presence of significant arrhythmias, where we talk about high-degree atrioventricular block, symptomatic ventricular arrhythmias, and so on. Symptomatic bradycardia and tachycardia, of course. We also talked about surgical risk stratification. This is also a very important issue, because if you have, for instance, a surgery where your patient is at risk of losing a lot of blood, then the trigger of becoming or developing myocardial ischemia is far higher than if you have a low-risk peripheral superficial surgery. So this risk stratification basically divides all the types of surgery in 3 types. And the most dangerous type of surgery is vascular surgery with a reported cardiac risk of about 5%. And then we're talking about major arterial surgery at the level of the aorta or the peripheral arteries. Then there is an intermediate surgery at risk, which means that you have a risk of developing cardiac problems in about 1 to 5% of the cases, which are intraperitoneal, intrathoracic surgery, carotid endarterectomy, head and neck, orthopedic, and prostate surgery. And then the low-risk surgeries are mainly endoscopic procedures and superficial procedures, which means, in fact, that if you have a low-risk surgery in a patient with a normal function, you can easily proceed for surgery. What will trigger you, or what will give you the best idea whether a patient can sustain your anesthesia and your surgery, is the exercise tolerance. And this is normally said in med. So if your patient can sustain physical effort of about 4 meds, then he can easily survive your anesthesia. What is 4 meds? Well, climb a flight of stairs, walk at the normal ground level at about 4 kilometers an hour. So that's and run a short distance. If a patient is capable of doing such things, then probably your anesthesia and your surgery will not give additional problems. Okay, where comes the problem now? The problem comes when you are not capable of assessing the functional capacity of the patient, not capable of assessment because the patient is not capable of telling you what he is doing, or is not capable of moving because of another problem, as for instance, arthrosis of the legs or such an orthopedic problem or neurological problem. At that step, you need to make an assessment on your own instead of relying on physical conditions. Well, then again, what the guidelines propose is that you again look at the clinical conditions. Are there 3 or more risk factors of myocardial disease, of cardiovascular disease? Then you need again to look at the surgery. Same is true for, so again, you look at the clinical condition of the patient and then assess the surgical risk and then start to treat if necessary. This is a very important point. You should only order additional tests or start a treatment, or you should only order additional tests if it will change your treatment. If you will not change your treatment and your type of anesthesia, don't ask for additional tests because you will not do anything with it. So this clinical risk stratification, what does this mean? Well, actually that refers to the so-called Lee Revised Cardiac Risk Index. It takes a number of risk factors in the history or in the presentation of the patient, actually comorbidities of this patient, and you count them. If you have more than 3, then your patient is at big risk. And which are these? Ischemic heart disease, cerebrovascular disease, congestive heart failure, insulin-requiring diabetes, and renal failure defined as a serum creatinine more than 2 milligrams per deciliter. This is called the Lee Revised Cardiac Risk Index. That's what you can do for any of your patients very easily. It doesn't take you more than 5 minutes. And based on this cardiac risk index, you can have an idea about the risk that a patient has. If your patient has more than 2 of these risk factors, the rate or the risk, the chance of developing cardiovascular problems in the perioperative period is about 10%. So 1 in 10 patients is at risk of developing a problem while you are giving your anesthesia. Okay, let's move. We discussed the flowchart of the American Heart Association. Let's move to the flowchart that was proposed by the European Heart Journal. And that's a flowchart. And you will agree with me, I hope, that this flowchart looks a little bit more complicated than the flowchart of the American Heart Association. And I will immediately explain you where the problem is. So again, the idea is start with assessing the urgency of the surgery. If it's urgent, go to surgery. Then move to an assessment of the cardiac conditions, or the active cardiac conditions. Assess the severity, the risk of surgery, and then assess the functional capacity of the patient. So more or less the same flowchart, the same steps, consecutive steps that are proposed by the American Heart Association. But then there comes a problem. Well, first of all, the surgical risk stratification is a little bit different, but it's more or less the same. High risk cardiovascular surgery patients, intermediate risk the intra-abdominal, the intrathoracic surgeries, and the low risk again, the superficial surgeries. So that's pretty similar. But let's look a little bit more in detail now at the different consecutive steps. Determine the risk of the surgical procedure. That's what we have done. That's known. If it's intermediate or high, go further. Have an idea about the functional capacity of the patients. And then in the European guidelines, which are mainly related to the fact that the group of Rotterdam was very prominently present and worked a lot with statins and beta blockers, you see that at each level, from step 4 to step 7, there comes an assessment with statin and beta blockers. So you look at your patient, you see he's at risk or you think he's at risk, refer him to the cardiologist for an optimization with beta blockers or with statin therapy. This is very interesting and probably a good thing to do. The only problem, and now I'm speaking for my country, but I'm pretty sure that's very similar all over Europe. The problem is that I don't have 2 months in advance before I have to operate the patient or anesthetize the patient. So this is theoretically probably very good, but who of you is capable of saying, okay, I think you need some beta blocking treatment or some statin treatment, go to the cardiologist, and I'll see you back in 2 or 3 weeks to see if your beta blocker is sufficiently working to be safe during anesthesia. This is actually not really feasible in a normal practical conditions. So in the last 4 or 5 years, there have been a number of issues with regard to the guidelines that were published by the American Heart Association and by the European Heart Association. And the issues I want to discuss with you is, first of all, the problem of perioperative beta blockade. Secondly, I would like to discuss with you the choice of anesthetic agents, will become directly clear. And then there is another more political issue that needs to be addressed. Let's start with the perioperative beta blocking therapy. You all remember, I'm quite sure, the big study that was published in the New England Journal of Medicine some, let's say 15 years ago by Dennis Mangano, where he administered atenolol to a number of patients and saw that mortality was significantly lower, morbidity and mortality, after a number of years. And starting from there, the group of Poldermans had a number of studies that went in the same direction, and at a certain moment, you were almost a criminal if you didn't give your patient perioperative beta blocking therapy. The only problem is this indeed a good therapy? And when more and more studies became published, it appeared that this was perhaps not really the good thing to do. And in 2005, Devereaux again published an interesting systematic review and meta-analysis of all the studies that had been published until then, looking at perioperative beta blocking therapy and outcome of the patients in all types of surgery. So, their basic idea is what was already known on the topic. Well, there was known that guidelines prescribed that you should give your patient at risk a beta blocking therapy. However, they were not convinced and they questioned this setting. So what they did was take all the published studies on the topic over and over again. And you see about 5,000 studies were initially identified as dealing with perioperative beta blocking therapy and outcome of the patients. But from these 5,000 studies, in the end, only 22 were considered to be of sufficient quality to be included in a systematic review. And if you look at a number of these studies that have been included, and you look at the different topics, the different points that are necessary to have a good randomized trial, so as concealment of administration, early stopping of the trial, blinding of the patients, blinding of the providers, and so on and so on. If you look at the quality assessment of these studies, you see that most of these studies had one or more problems in the methodology, indicating that all the evidence that comes from this study includes a very, very high risk of bias. And actually, this is one of the big problems with the perioperative beta blocking therapy. This slide shows you the relative risk of developing a major perioperative cardiovascular events, whether you are treated with beta blockers or whether you are not treated. And here is a so-called line of equal risk, which means that when your point falls on this line, the risk of developing perioperative problems is similar for the beta blocking treated persons as for the control persons. As you can see, there is some suggestion that there is some kind of protection, but it's very, very borderline. And this is certainly an issue because when you look at the number of events, we're talking about 28 events in one group, in the study group, the beta blocking treated patients, and 55 events in the control group. When you are talking about outcome and your event rate is that low as you would see it here, it's very dangerous to make conclusions about potential therapeutic effects. So, the conclusion of this study was that perioperative beta blockers may decrease the risk of perioperative cardiovascular events, but that was at the expense of an important increase in the risk of perioperative bradycardia and hypertension. Very importantly, and that's what you should remember, is that this conclusion was based on a very low number or a very low incidence of events. So at that moment, the suggestion was that perhaps perioperative beta blockers could have a beneficial effect, but that this was very, very borderline, and that new studies or major studies should have to be performed. And actually, the same guy who read the systematic review was a coordinator of the so-called POISE trial. We had looked to the effects, after the effects of the use of the start of a perioperative beta-blocking therapy, with metoprolol in this case, on outcome of the patients. And here you see the flowchart of randomization and inclusion. About 10,000 patients were randomized. Finally, it's more than 4,000 patients in each group, which means 4,000 patients were treated, 4,000 patients were not treated with beta-blocking therapy. Just for your information and to give you an idea about the background of this study, these are the doses that were given. Before surgery, 100 milligram metoprolol, then within the 6 hours after surgery, another 100 milligram, and then afterwards, during 30 days, 200 milligram. I think you will agree with me that certainly for a start of a perioperative beta-blocking therapy, these are important doses. Okay, what are the results of this study? When you look at myocardial infarction, well, there seemed to be a clear benefit. This is the patients treated with beta blockers. These are the control patients. So it seems, and it was significant, yes, beta-blocking therapy is capable of decreasing your incidence of perioperative myocardial infarction. This is a very good thing, because if it decreases perioperative myocardial infarction, it decreases the risk of developing problems. However, what appeared is that with this decrease in myocardial infarction, the incidence of stroke occurring, perioperative stroke occurring, was significantly higher in the group, beta-blocking treated group. And this incidence of stroke was completely related to the occurrence of perioperative hypertension, to the incidence of perioperative hypertension. So you protect your patient against myocardial infarction, but the number of patients develop hypertension, and secondary to this hypertension, seem to develop stroke. And when they put all the data together, all the comorbidities, all the outcome data together, it seems that the beta-blocking treated patients are at higher risk for mortality after 30 days. So we believed for many, many years that we should give perioperative beta-blocking therapy. This study clearly demonstrates that yes, you decrease your incidence of myocardial infarction, but you increase the incidence of mortality. So probably we should not give beta-blocking therapy. Recently, 3 years ago, there was an interesting meta-analysis of all the studies that have been performed after including the POISE study. Again, 112 trials, about 10,000 patients included, so you have more or less an idea, sufficient patients to talk about outcome. And this meta-analysis showed that there was no reduction in the risk of all-cause mortality, no reduction in the risk of cardiovascular mortality, and no reduction in the risk of heart failure. What is so? Taking all these studies together, there is a decrease in non-fatal myocardial infarction, which is a good thing, but of course, and a decrease in myocardial ischemia. But this is at the expense of an increase in non-fatal stroke, perioperative bradycardia, perioperative hypertension. So, actually, at this moment, we can say that there is actually no hard evidence that supports the use of a beta-blocking therapy for the prevention of perioperative clinical cardiac outcomes, at least in patients, and that's very important, in patients undergoing a non-cardiac surgery. And their suggestion was at that moment, okay, the guidelines should probably be softened, should probably be readapted in function of these data, at least the guidelines concerning beta-blocking therapy. So you have two parts, in fact. One part, which in time was a Rotterdam group, saying, okay, beta blockers remain very important in your treatment of perioperative cardiac problems, and the group of the POISE study who said that probably beta blocking therapy should not be routinely applied. And all this discussion led to the fact that in 2009, the American guidelines were re-updated with regard to beta-blocking therapies. And what you should know at the moment, the thing to do is, well, beta-blockers should be continued. If a patient is on beta-blocking therapy, you just continue it. In patients undergoing surgery and who are receiving beta-blockers, that's very clear. Don't stop a beta-blocking therapy. Should we start a beta-blocking therapy perioperatively? Well, if you consider starting it, you should really titrate it to heart rate and blood pressure in high-risk surgery patient, in vascular surgery patient. The question then is, should you give this beta blocker just before you start the induction of your anesthesia, or is it preferable to modulate hemodynamic variables during the intraoperative period? The usefulness is uncertain for patients undergoing intermediate surgery and actually routine administration, like we used to do some 5-6 years ago, routine administration of beta blocker in each patient you suspect to be at increased risk, which means each patient above 50 years is not indicated anymore. Then there is a second issue that I would like to discuss with you, which is the intraoperative anesthetic management. If we go back to the American guidelines of 2007, you will see that these guidelines with regard to the choice of anesthetic technique and agents suggest that it may be beneficial to use a volatile anesthetic agent. There was a class 2A recommendation with a level B of evidence. Level B of evidence means, you can see it, that it's the limited evidence available for this risk, for this assessment. Well, actually, dear colleagues, at that moment, there was no evidence at all about the use of any anesthetic agent in non-cardiac surgery. In cardiac surgery, there have been some indications that the use of a volatile anesthetic agent might be beneficial compared to intravenous. But in non-cardiac surgery, at that moment, there was no evidence at all, no publication at all. So these guidelines are, in fact, completely wrong, and the level of evidence completely wrong. So that's why in the European guidelines we did not repeat these guidelines, and there is clearly stated that the choice of an anesthetic agent was probably of little importance with regard to the outcome of the patients in non-cardiac surgery, as long, of course, as you keep hemodynamics stable. But that's what we do each day, so that shouldn't be the problem. So no evidence of superiority of any specific anesthetic agent in non-cardiac surgery. In the meantime, there have been 2 articles that looked more or less, not really as a randomized controlled trial to association between volatile anesthetics or intravenous anesthetic agents and outcome. One study was published by Philip van der Linden from Belgium, where in another, as a side observation from another study looking at goal-directed therapy, observed in vascular surgery patients, so the high-risk surgery patient, that the incidence of major cardiovascular complications was lower, significantly lower, with a volatile anesthetic agent. The only study that really prospectively looked at the choice of intravenous versus volatile anesthetic agent in non-cardiac surgery, abdominal vascular thoracic surgery, was done by the group of Landoni and his colleagues in Italy. They had about 150 patients, a number of patients dropped out of the study, and finally they had 44 patients in one group, intravenous treatment, 44 patients with the volatile anesthetic agent treatment. These are very low numbers. But anyway, these are the conclusions. When you look at the incidence of cardiac events, you can see no difference at all between the groups. So this seems to suggest that your choice of anesthetic agent will not make any difference. That's very interesting. But can you say, or can you come to such a conclusion if nothing occurs? They had high-risk patients, I agree. But if you look at the incidence of events, 0, 0, 0, 0, 0, 1, what do you want to prove if you have no events occurring? So this study is essentially negative, but not sufficiently powered to address the issue of outcome and choice of anesthetic agent. And that's what I tried to develop and explain in an editorial that accompanied that article. Another issue are the neuroaxial techniques. Will the use of an epidural anesthesia improve outcome of the patient? Well, there are huge amounts of studies on the subject, but all very, very small studies. So it's best to look at the meta-analysis where they take all the studies together and try to come to a conclusion. And actually, there have been two very interesting meta-analyses and studies on the subject by the same group, published in Anesthesia and Analgesia 4 years ago. When you look at the different outcome variables, mortality, cardiovascular disease, cardiovascular problems, pulmonary, and so on, between epidural and general, you can see that there seems to be no difference. Very recently, no, not really, but there was another meta-analysis by a Canadian group who is very good in making meta-analysis, and this was what they saw when they took all the data together and looked at 30-day mortality. You can see that you get a rather blurred spectrum, which means that there seems to be an overall effect suggesting that there is a lower mortality. But this is not the case in abdominal surgery, not the case in vascular surgery, and very borderline for the choice between high-volume hospitals and not. So it's a very difficult picture, and you can't really say very straightforward use of epidural anesthesia will be related with lower mortality. So the conclusion is that epidural anesthesia and analgesia in this meta-analysis seem to be associated with a small improvement in 30-day survival. However, there was a very, very small effect size. It means that in each of the 500 patients, possibly you could save one patient by using an epidural analgesia. There was no compelling evidence that epidural anesthesia improves postoperative survival, but on the other hand, it supports the evidence that this technique can be used rather safely, not to improve outcome of the patients, but, for instance, to be used as a pain treatment modality or to prevent or decrease the risk of pulmonary complications. And then I need to come to the last issue, which is more or less regrettable diplomatical and political issue. And I address this issue because we had a number of reactions at the level of the board of the European Society of Anesthesiology about people that were concerned by the situation of the chairperson of the Guidelines Committee, which was Dan Poldermans. As you're probably aware of, certainly the Dutch people aware of, Professor Poldermans was dismissed from his hospital for suspicion of fraud. And now the question was, how does this situation has impact on the outcome, on the reliability of the guidelines? He also resigned from the European Society of Cardiology, of course, and then both Erasmus Hospital in Rotterdam and the European Society of Cardiologists started an investigation. But it was stated at that moment already very soon that these guidelines are based on contribution of many European experts. You saw the list of authors, all these people have actively contributed. So it's not, these guidelines are not the result of the ideas of one person, it's really a consensus statement of all European experts. These were based on the best available evidence, including many studies from different nations. So these guidelines, both the American guidelines as the European guidelines, were not based solely on Polderman's study. They are therefore the result of a good discussion and not an individual statement. Well, it is still ongoing, the inquiry by Erasmus Hospital and by the ECS. And as you might have noticed, our past president, Paolo Pelosi, has written a letter on the topic in the winter newsletters just published a few months ago. We have a problem here. There is suspicion of misconduct by one of the people by one of the persons involved in this task force. So what I try to do for you is to look whether the involvement of these studies has an impact on the recommendations. Pollemans has published a lot of articles together with Professor Bax, who worked at Leiden. And at a certain moment, when the Pollemans issue came out, Leiden University said, okay, we're going to do an independent investigation looking whether Professor Bax is involved or not. Very recently, which means last 2 months ago, I think, 2 months ago, they came to the conclusion that there was no reason, there were no arguments to suspect Professor Bax of being implicated in any fraudulent report of data. So let's then go back to the guidelines. If you look at the guidelines and look at the references that were used to make the recommendations, 33 of the 238 references come from the group of Rotterdam of Poldermans. And from these, only 5 are without Bax as a co-author, which means that potentially, if these 5 are used, then there could be a problem. Well, I looked them up for you. It's 1 review article, 1 survey, 1 consensus statement, 1 letter to the editor, and a cohort study that was not related to the recommendations. So I think there is no issue. You can be completely reassured. These guidelines are completely reliable. So this brings me to my conclusions. Perioperative beta-blocking therapy. Yes, in those patients who are treated with beta blockers, don't start it just before the operation, titrate it eventually during the operation. Are there indications that there is an influence of intraoperative anesthetic management and outcome? Until now, we don't have any data that would indicate that you should make, in non-cardiac surgery, that you should make the choice for any technique or any agent. What is important, and that's my last statement, what is important if you have guidelines is that at a certain moment you start to monitoring whether these guidelines are followed. We have published a number of guidelines in the EGA with the European Society of Anesthesiology. We will certainly try to have a follow-up in the upcoming years whether these guidelines are implemented or not. And to see how important it is, there's a very recent German article where the group of Frank Rappler looked at the fact whether these guidelines were followed or not. You are all member of the European Society of Anesthesiology. You get the European Journal of Anesthesiology. We have published a number of guidelines. Please give us your feedback. Do you use it? Do you use these guidelines, these recommendations, or don't you? Why do you use them, or why don't you use them? This feedback is essential for us to develop and to adapt the guidelines to the actual situation. So please respond. Please send an email to me or to the European Society of Anesthesiology if you have any comments on this. Thank you for your attention.
Thank you very much, Stefan, for an excellent and comprehensive lecture and for your gentleman approach to that political problem. The forum is now open for questions. I would like you to present yourself and use the microphones if you have a question. Please, was it all clear? Yeah, please go to the microphone, identify yourself. I would appreciate that.
My name is Faris Kousa. I work in Wigan in Britain. Is the risk increased in patients who did not have a myocardial infarction but had coronary artery bypass graft and they are in stable condition? Thank you.
In stable condition, you say?
Yes.
Stable condition.
Yes.
Actually, these patients should be considered as completely cured, so I would consider these patients not at risk.
Ming Lo from Sydney. My understanding is the POISE investigators are going to branch out to look at medications, including aspirin, on top of the beta blockade.
Yep.
What are your thoughts on the matter? What is the preliminary evidence? Is there other studies out there following the same lines?
Well, there is actually the POISE 2 study ongoing where they're looking at alpha-2 agonists and aspirin. And this study is ongoing, recruiting all over the world. I think they're at the moment at 1,500 inclusions of the 10,000s. So I think in the upcoming 2-3 years we will have more information on that.
We've learned, yeah.
From Zurich. I have a question to the epidural anesthesia and general anesthesia. In the guidelines, during reviewing the studies, did you review the successful implementation of epidural anesthesia, thoracic or lumbar anesthesia? We know that in there is a high incidence of not full successful implementation or only a semi-implementation of that. And could it be an impact on the effect of the anesthesia and outcome of the patients, this anesthesia? Thank you.
That's a very interesting issue you address because it's in fact two questions. First of all, is epidural anesthesia, does it make a difference? Or is it the way in which you use epidural anesthesia that makes a difference? I think actually with what we know, we have no evidence that the implementation of an epidural anesthesia improves outcome. But I can't answer you to the fact whether it's related to the fact that epidural anesthesia doesn't alter outcome or to the fact that not everybody is optimally treated if you assume epidural anesthesia to be an optimal treatment. It does not mean that if epidural anesthesia does not alter outcome, that it can have a good effect on postoperative pain relief or respiratory complications. That's a completely different issue. Here we looked only at the relation between the choice of anesthetic agent and the outcome.
I would like to take the defense for Dutch anesthesiologists and even more so, of course, for the Belgian anesthesiologists who do not adhere to guidelines. Stefan, maybe one of the reasons is the credibility of these guidelines, because you pointed to a major mistake in the American ones where they just translate data from cardiac surgery into non-cardiac surgery and recommend the use of volatile anesthetics. Do you have any comments on that?
Well, the comment I have is that at least in these guidelines you get the best available evidence. And that's probably the most important point. If you look at that one single study, it's easy to prove with some methodological problems that one is better than another. Here in the guidelines you have the best available evidence. And that's where guidelines and recommendations are based on. If this best available evidence changes over time, so be it. But that's also, and I take the opportunity of your question, to again ask all of you to give comments on these guidelines. If you do not implement them, tell us why you do not implement them. If you don't believe them, tell us why and which guideline or recommendation you don't believe them. It's only then that we can move forward. Thank you for giving me this opportunity again.
We have learned our lesson with the beta blockers, of course, because many years ago you and I defended or recommended the use of beta blockers based on that available evidence at that time, right? And now I'm kind of scared that we are going to throw away the child with the bathing water, as they say, the baby with the bathing water, by not using or recommending beta blockers because they might be dangerous. First of all, you already pointed to the fact that actually there was a high dose of beta blockers acutely given and no titration to effect at all. So maybe it is up to us to find the correct doses of beta blockers. But the question I wanted to ask you is, with statins, we are now cautious of making the same mistakes, recommending them and then having to withdraw the recommendation because of a side effect. Or do you see statins as relatively safe, much safer than beta blockers? And so should we be less cautious of giving statins? Is there any risk associated with them?
Well, 10 years ago, I was convinced that beta blockers were also safe until the POISE study proved otherwise. So there is a definite risk that we will have the same story with statins. What we know for sure is that if you interrupt beta-blocking therapy or you interrupt statin therapy, your mortality and your morbidity perioperatively increases. So that's the only thing you have to know. Don't stop a current treatment. There is also no reason, certainly in patients who are not really at risk, to start a treatment the day or the week before the operation, because it will interfere, certainly beta blockers will interfere with your hemodynamic stability perioperatively. We have good and safe anesthetic agents. We are capable of maintaining hemodynamics within good limits in our perioperative period. So treat the patient when it's necessary. If it becomes hypertension intraoperatively, you treat the hypertension intraoperatively and not preoperatively.
Okay, any further questions? So if not, I would like to thank the speaker again, and I thank the audience for their interaction. And please fill out the score forms that were handed to you. Yes. See you later. And you stay on.